Welcome to EJB Talks, Rutgers Blaustein School experts in policy, planning, and health, where we talk with our faculty and staff experts, as well as students, about how the fields of public policy, urban planning, public health, health administration, and public and urban informatics affect your lives. Welcome to EJB Talks. I'm Stuart Shapiro, the Interim Dean of the Blaustein School, and the purpose of this podcast is to highlight the work my colleagues and our alumni in the fields of policy, planning, and health are doing. We are spending this, our 8th season, meeting with our new faculty at the Blaustein School. We hired more than 10 in the past year in a wide array of fields, as the shows this season will demonstrate. Today, we're talking to one of our new professors in the public health arena, Professor Shar Williams. Welcome to the podcast, Shar.
Thank you so much, Stuart.
So, you're new to the Blaustein School as a professor, but you're not new to Rutgers. So tell us a little bit about your history with this venerable institution.
Happy to. So, I guess X number of decades ago, I attended the illustrious Douglas College. Very proud of my alma mater. I spent my undergrad career at Douglas College at Rutgers University here in New Brunswick. And I truly treasure my years as an undergrad at Rutgers. Not only do I have the best memories and made lifelong friends, my sophomore year roommate is my best friend to this day, but this is also where I discovered research and public health, and that's where I discovered my love and affinity for teaching as well. So lots of beginnings here at Rutgers.
And you decided to come back, so you really did like it.
I did. Best evidence.
We're grateful for that, for sure. Now, within Rutgers, of course, within your the vast array of fields you could have studied, you chose public health, and you chose sort of the disparities that we've seen in public health to study. What made you do that?
I guess, let's see. I took a circuitous route to public health. I was an economics major, math minor as an undergrad, and I thought, I'll go work in corporate America. That's what I thought. But one day, the winter of my junior year, a flyer kind of happened in front of me. It was at Douglas Student College, and it was a flyer for a summer program, Project Learn. It no longer exists here, but it was a training program, a summer intensive that introduced students to research. You were paired with a mentor. You were able to take some course in research methods and be introduced to statistical software. And I think build curiosity, ask questions, and get some foundation to help you make decisions about whether or not you could go on to grad school. And that's really what kind of piqued my interest. So there I was able to really learn about health disparities, and not only what they were, but kind of how they come to be, not by happenstance and not just through your social identity, but through like a whole host of history and political and important contexts. And so, I mean, I don't know if I'm showing myself as a nerd, but what's more fascinating than that, like seeing how these things kind of play out, and it just breeds more curiosity is what happened. And so I thought, what a great way to use some of the quantitative skills I have then to kind of learn more about those things that interest me. So that's my route to public health and health disparities, and then kind of mixing it with my interest in quantitative skills. And so thinking about how I can use those to answer interesting questions or pose new questions. Just been fascinating.
That's great. I will tell you two things that you have in common with many of our other guests. First of all, many of us took circuitous routes to get where we are today. 25-year-old me would never believe it if you told him he was. I was a dean, much less a professor. So yeah, we all took a strange path to get where we are. And second, as much as we might all want to deny it, we're all nerds. So we wouldn't be doing what we did if we didn't have some serious nerdy qualities in us there. So you're among friends in both of those. So you said you get to study interesting questions. I want to ask you a little bit about some of the interesting questions that you do study, and you study some really tough stuff like depression and suicide and PTSD. Before we sort of get into your findings on this is obviously not an easy area to get data on. So I'm wondering, where do you get the material that you use to, apply your quantitative skills to these really hard questions?
Where do I get my data? So part of my circuitous route is that I collected a lot of degrees on the way. So in addition to having an MPH, I have graduate degrees in biostatistics. And I think one of the benefits of that is that there's always a need for a biostatistician, and there's always really qualified researchers doing exciting work, and they need a methodologist on their team.
Mm.
And so I think since my grad school years, I've been able to participate and collaborate on a lot of really interesting studies. And I just was able to, or blessed to make a strong collaboration with a developmental psychologist, a researcher who was doing work that very closely aligned with mine, and was in a place that was able to welcome not only my expertise as a statistician, but able to invite my independent research and my subject area expertise. And so it was really just um, a really perfect coincidence that's really been rewarding for me. So I'm able to kind of exercise my quantitative methodologic skills
Mm-hmm.
and start asking interesting questions and answering those questions, and really play a role in building up kind of what kind of questions get asked and what kind of work we can look at.
So let's get to those answers then. What have you found regarding these key factors that lead to these disparities between more well-off white populations and Black and Latinx populations, particularly regarding these tough issues like anxiety and depression?
The work I've done in this area, depression, suicide, anxiety, PTSD, has largely focused on survey data.
Mm-hmm.
And both data sets that I've worked on actually are collected from populations in New York. And so one's based out of Washington Heights, which I'm not sure if many know, predominantly Latinx population. And then the other is a longitudinal study that collected first in 1990 in
Mm.
East Harlem from middle schools and high schools. And so that population is predominantly Black and Latinx.
Mm-hmm.
And in both these populations, we've asked important questions about socioeconomic disadvantage, other experiences with respect to racism, discrimination, experiences in the healthcare treatment facilities, and also able to ask questions, important screeners like the PHQ 910, which is a 10-item screener for depression,
Mm.
and other important screeners for PTSD and anxiety, and able to associate experiences of discrimination, socioeconomic disadvantage, and important mental health outcomes. And I'll kind of highlight two main findings.
Great.
In one particular study, my interest really is looking at the diagnosis of these conditions, and so in that study, we're looking at how many people have been diagnosed by a medical or clinical provider,
Mm-hmm.
and then looking at results from screeners that give an indication of symptomology of these diseases, to
Right.
look at how many are actively diagnosed and potentially in treatment, and how many have undiagnosed mental health conditions and are not receiving treatment, as an indication not only of like undiagnosed mental conditions,
Sure.
but also to kind of speak to some non-traditional assessments and means of identifying this population, which is known to have less traditional symptomology with respect
Yeah.
to depression, anxiety, and thinking about how these screeners and how these clinical diagnoses work, and thinking about which other partners can be involved in the diagnosis and treatment of populations, marginalized populations, right? So thinking of non-traditional
Hmm.
routes of accessing care, thinking of ways to get folks into screening and therefore treatment. So that's one aspect of it, the diagnosis and the identification. And
Hmm.
then the other aspect of it is looking at the impact of exposure to discrimination, socioeconomic
Mm.
disadvantage on health. And one of those health outcomes is depression and anxiety. So there's kind of like two things going
And so you just so it's clear in my mind,
on.
so you do find a lot of sort of undiagnosed conditions, people that are sort of scoring high on the screener, if you will, but not having formal diagnoses, is that particularly among these disadvantaged populations?
Exactly. So what we find there, and in that study, we have both non-Hispanic white, people of Latinx and Hispanic descent, as well as African American and Black populations in the Washington Heights sample. And what you see is higher levels of undiagnosed depression among marginalized communities. And in that particular paper that we are discussing, we also talked about what that looks like in terms of cost with
Right.
respect to quality of life.
So and you may not know this because it's probably outside the scope of your study, but do the lack of diagnoses come because people don't think to go to a doctor and talk about these symptoms? Or is it because they go to the doctor and probably because of who they are, the doctor dismisses these symptoms as possible signs of a medical cause? Or is it something else entirely?
It kind of is a little bit out of my scope, but in my discussion and in my thinking about this topic, and as I am wont to do, go off on tangents, and so I've done quite a bit of
Me
reading
too, as you notice. Yeah.
on it. And I think a number of things can be happening here. There are considerations with respect to how these diagnostic criteria are developed and
Uh-huh.
the populations on which they're trained on. And so there is that consideration about whether some of the populations that are represented in my study, some of these marginalized groups, are they a part of the clinical assessments and development of these diagnostic criteria.
Hmm.
And then the other thing is about the relationship between these populations and health services. Um, and so whether or not they're actually seeking that kind of care or they're in the space to get that kind of care. And in some of my reading, I did find that there is now some healthcare organizations have started instituting like a PHQ-2. So that's a 2-item questionnaire
Mm.
screener for folks who walk into the ER, for example, so they can get a little
Ah.
screener to be more quickly identified, because many times you don't get to see these patients and be able to give them this kind of screening or be able for them to get this kind of attention. And then another thing was, which is related to the first point, is how depression or mental ill health kind of shows up in different populations, and whether not only the screeners and the tools that are used to assess, but whether the places that people attend for that kind of support. So maybe it's not a medical location. Perhaps we need to be looking at community organizations. Perhaps we need to be looking
Mm.
at traditional places of care, which sometimes can be religious organizations and some groups, or some other kind of social spaces. So those are some of the things I've been thinking about and I've read about.
Mhm.
But yes, not really directly in my exact scope, but certainly something I'm interested in and have been reading quite a bit about.
Right. I don't imagine you can be immersed in these things and not think about those kinds of questions
Right.
as you're doing them. Relatedly, your answer sort of points a little bit in this direction. What in terms of the what do we do about it? And you talked about churches and community organizations. You talked about changing diagnostic tools, et cetera. Are there anything else we should be thinking about as implications of your work?
You know, to go back to the changing of the diagnostic tools, I really, truly, the crux of the matter is a lot of the burdens, so the exposures to discrimination and financial distress and
Mhm.
life stress, um, kind of get under the skin and
Mm,
affect people physiologically. And this is what we see when we talk about allostatic load and cumulative stress and weathering related to experiences. And so I almost back off of the diagnosing and really focus in on all the structural or the systematic and systemic
right.
ways in which marginalized folks are experiencing distress and stress, and how that shows up in your mental health outcomes, but also in your biologic, like physical health markers. And so I guess it's me wanting to highlight more a lot of the structural
Hmm.
and systematic ways that this burden kind of is built, and not focusing too much, not for lack of importance, but just for the fact that like you have to focus somewhere,
Sure.
um, on those kinds of exposures, while recognizing that, of course, how one diagnoses and kind of, I feel like that's more tied to payment, and I
Right.
want to focus more on the structures that exist, to kind of perpetuate a lot of these health outcomes.
Right. Well, that leads me to my last question. What next? What kind of what can you tell us about one or two sort of things you're going to be working on in the next year or two?
Oh my goodness, one of the harder questions to answer because I have so many
I
ideas.
know you got to pick out the one that our
Pick
listeners
out
are going to be
one.
like, "Ooh, that sounds cool."
So I think closest at hand, I'm working on some papers that look at the association between discrimination and socioeconomic disadvantage and allostatic load. So I'm quantifying
Mm-hmm.
cumulative stress using a number of biomarkers, from saliva, dried blood spot, as well as some anthropometric measures to create an index called allostatic load, wanting to see how discrimination and economic disadvantage kind of gets under the skin, um, to lead to this cumulative stress burden called allostatic load, and how that in turn impacts health. So that's where I am right now.
How are you going to measure the independent variables there, the discrimination piece?
So the discrimination piece, it's a good question. So right now we have about 30 years, 8 time points of self-reported experiences of interpersonal discrimination,
Okay.
internalized discrimination, as well as a number of measures on socioeconomic disadvantage having to do with educational attainment, income, and financial stress. But I'm hoping in the very near future, within the next year or so, to extend this work to include measures of structural racism. So we have for these individuals also residential information, and so we can try to, as best as we can, capture inequities on a number of socioeconomic markers at the zip code level, and to see how we can incorporate that in the analysis. But that's further out.
Yep, yep, yep.
Yeah,
I can see that. Yeah, like housing and education and
exactly. Incarceration,
yep.
etc.
Gotcha. Fascinating stuff. Shar, thanks so much for coming on the podcast.
Thank you so much for having me. This was fun. Of
We'll have you back.
course.
A big thank you to Shar and as well to our production team, Amy Kopp and Karen Olson. We'll see you next week with another talk from another expert at the Blaustein School. Until then, stay safe.